The third trial that looks at immunotherapy purely in the post-operative setting, it's called Ambassador. This is called by Dr. Apollo at the NCI, and other colleagues are working on it. We had this trial open at our institution. We accrued many patients. This trial is close to accrual. About 700 patients were accrued. We do not have data yet, but this is comparing pembrolizumab, anti-PD-1 checkpoint inhibitor immunotherapy compared to observation, and we have to see what this trial shows. It can be like a tiebreaker, right? We had a negative trial before, a positive trial, and we'll see what happens with this Ambassador trial. And there will be a lot of science and what we call translational research. So people who are going to look at blood collect from those patients, the cancer tissue, trying to learn about the cancer, trying to learn what we call the biology and immunology of the cancer in the laboratory, so we can become smarter and develop those biomarkers to help select which treatment we should give in the future. So a lot of interesting science comes with that trial. A different clinical trial, very different, not immunotherapy, is led by Dr. Pal and Dr. Danesman, both here in the West Coast. I'm involved in that trial as well myself, in the design and the conduction. This is a different concept, though. We check the cancer tissue for the presence of a mutation or fusion, as we call it, of a gene called FGFR3. FGFR3. If that mutation or fusion of this change in the DNA happens in that particular gene, and we can test for that using the cancer tissue from the surgery, the nephroureterectomy specimen or the cystectomy specimen, these patients may be candidates for this trial because the treatment here is an FGFR3 inhibitor. So it tries to target that mutation, that genetic change that happens in the cancer. We try to target that with this drug called infigratinib. Is a pill. It's an orally available pill that we evaluate whether it adds value compared to placebo pill to see if it makes a difference in the disease-free survival. Again, the time until the cancer comes back or death, that's disease-free survival is defined. And we try to, of course, prolong that and reduce, if possible, that's the goal, the chance of cancer coming back. And hopefully the goal ultimately is to cure more patients. So that's why we're doing this clinical trial, to see whether this FGFR inhibitor adds value or not. So to conclude here, I told you a lot of things. Think about cisplatin-based chemotherapy if the body is fit enough for cisplatin, and the medical oncologist can make that determination after talking to the patient. Clinical trials is very important. That's how we made progress. Everything I showed you today came from clinical trials. That's our vehicle, our tool to make progress, to help the patients, give them access to innovative, promising, and encouraging therapies with a chance to help them directly, but also learn from that, right? Learn from the clinical trials to help move the field forward, push the field forward, and develop more therapies and more biomarkers for our patients. We talk about the role of cisplatin-based chemotherapy, ideally before radical surgery, radical cystectomy, for example, for bladder cancer. We talk about the role of post-operative nivolumab based on the CheckMate 274 trial. There is no data about overall survival yet, but FDA approved that based on disease-free survival as of August 2021, as I told you, based on that trial. Ambassador trial finished accrual. This is the adjuvant pembrolizumab versus observation. We do not have data yet, results pending, and we're still accruing actively on this trial with infigratinib, the FGFR inhibitor, in those patients whose cancers have this particular mutation that we talked about in FGFR3, mutation or fusion of that gene. And then we talk about the promising role of circulating cancer DNA floating free in the blood. We do not know yet its exact role and whether it should or not guide treatment decisions, but a lot of research and studies are looking into that. It looks very promising for the future. And we have also an interesting variant histologies, try to offer dedicated trials for those variant histology types, because we need to learn about them and offer better therapies to our patients. It's always important, as I mentioned, to have a good discussion with your provider. Think also about, other things like family history in the broader family. Is there any predisposition to cancer or not? And should that require what we call genetic testing or genetic counseling to inform potential genetic predisposition to cancer that can help the patient and the broader family? That's a broader comment. It's not necessarily related to this talk, but something that we learn more and more about, and I want to bring it to your attention to talk about genetics and family risk of cancer to benefit you and your broader family with your providers. Overall, I'm very excited about what we have achieved as a broader global team moving the bladder cancer and upper tract urothelial cancer and urethra cancer, all of those urothelial cancers in the last few years. And I would say significant progress has been made, but still we have a way to go. And we need to work together with patient advocates. Bladder Cancer Advocacy Network is a great example. There are many other patient advocacy groups globally, and of course, other stakeholders, industry, academia, governmental agencies, foundations, FDA, the NCI, many other stakeholders to help, develop the policies, increase awareness, fundraising, and hopefully we'll have more treatments for our patients. Hopefully in the future we'll have better diagnostic tools. Maybe in the future we'll develop better screening tools because bladder cancer screening is not there yet. So we have to think about how to improve upon the ability to screen, detect earlier, and treat bladder cancer and help our patients live longer and live better. With that note, I would like to thank you for the kind invitation, thank the GRACE program, and hope you found this information useful, and as well as the information provided by many colleagues and great leaders in the field that are also talking in that program. Thank you.